Here I am again. Hello and welcome. My name is Violet Aso-Akek, a lecturer at the Kenya Medical Training College, Nairobi campus. This is the third of our series in acute inflammation, and today we shall be looking at the effects as well as the outcomes of acute inflammation. So welcome. So we shall begin by looking at the beneficial effects, that is the good ones. Then we shall look at the not so good effects of acute inflammation. So when we are talking about the beneficial effects of acute inflammation, we are actually making reference to the effects of the exudate that is formed during acute inflammation, as well as the presence of the white blood cells at the site of inflammation. The exudate brings its benefits in two ways. Number one, by helping to bring in certain good things that help with the process of inflammation and helping to wash away the other undesired particles that could be present at the site of inflammation. And then we are also talking about the white blood cells. And when we are talking about the white blood cells, we are basically making reference to the act of phagocytosis, because it is by phagocytosis that any bacteria or microorganism that could be causing the inflammation or could be superimposed on the inflammation are removed. Dead cells and other tissue debris are also removed by means of phagocytosis. So these are the two main ways by which we experience the benefits of acute inflammation. So number one is dilution of toxins. This is conferred by the presence of the inflammatory exudate. That means when the inflammatory exudate forms at the site of injury, it helps to neutralize the concentration of whatever it is that is causing the inflammation. Be it chemicals, be it toxins, be it the microorganisms, they are diluted by way of presence of the inflammatory exudate. And at the same time, remember we said that the inflammatory exudate is washed away or cleared by means of the lymphatics. So by that, when the exudate is being cleared, it also carries along with it whatever toxins or some of the bacteria that may have been at the site of injury. And that helps to eliminate or limit tissue injury by those chemicals or microorganisms. So the second benefit is promotion of immunity. So we are saying that the exudate formation is usually cleared by the lymphatics. And remember, the lymphatics drain via the lymph nodes. And the lymph nodes are secondary organs of immunity. So when the lymphatics are draining the exudate, which could also be carrying in it microorganisms, these microorganisms gain access to the lymph nodes. There, they may trigger an immune response. Now, when that happens, antibodies will be formed, accordingly specific antibodies, either against the microorganism or against toxins that could be at the site of inflammation. Then these will come back as protective antibodies. So we are saying that microorganisms will be carried to the lymph nodes via the lymphatics when they are draining the exudate. The presence of microorganisms reaching the lymph nodes will trigger an immune response. When the immune response is triggered, the end result is we shall have production of antibodies or T cells that are specific to the microorganism, that are specific to the offending toxin. Now, when the exudate is forming again, now it is coming back carrying proteins. And we know that antibodies are also proteinous in nature. So they'll be part of the proteins that will be coming back at the site of injury. And that is how now inflammation becomes beneficial in terms of promoting immunity as well as bringing with it the protective antibodies. So that is how it happens. Now, fibrin formation. Fibrin is formed from fibrinogen, and this fibrinogen is usually present in the inflammatory exudate, and it forms by action of tissue thromboplastin. When fibrinogen is exposed, it will be converted to fibrin by the action of tissue thromboplastin. These things, the details, you will be able to learn them if you haven't already in physiology, how that happens. So the presence of fibrin will usually form a mesh around or within the site of inflammation, and this mesh is beneficial in the fact that it delays bacterial spread. It delays or prevents the spread of bacteria from the site of injury to the adjacent tissues. It also tries to prevent or delay the spread of toxin from the site of injury to the other adjacent tissue. And when that happens, then the phagocytes, the white blood cells, are given ample time and opportunity to be activated and cause phagocytosis. Plasma mediator systems, these are just the mediators of inflammation. Remember, for the inflammation to continuously take place and for the body to enjoy its benefits, then the mediators of inflammation must be on site. Like I said before, we shall look at the mediators inflammation in another separate session. So we are saying that other than the presence of antibodies, other than the presence of fibrinogen, which is converted to fibrin and then prevents spread of the noxious element, the presence of mediators of inflammation is very important. And these include the complement system. The complement system helps with opsonization. Remember, we talked about opsonization and we said that this is the enhancing of adhesion between the phagocyte or the phagocytic cells and the particulate matter that is supposed to be phagocytosed. That particulate matter could be microorganisms, it could be dead cells, and so on and so forth. So complement is very important. Then we have the coagulation pathways. So the activation of the coagulation system will usually help to limit the spread of offending causes of the inflammation. And particularly when we are talking about microorganism, then when they are confined in one place, that tends to enhance the process of phagocytosis, because then they are put in one place and the white blood cells or the phagocytic cells are able to reach them and phagocytose them. Fibrinolytic system, this provides the means of fibrin deposits and blood clots from the site of inflammation. That means that once the clot has formed, remember the fibrinogen and fibrin and clot formation, once this has been formed and its job is done, then the fibrinolytics come in to break down the blood clot because it is no longer needed. Then we have the kinin system. The kinin system helps in vascular permeability as well as vasodilatation. Remember, without increased vascular permeability and without vasodilatation, it is not possible for exudate to form. It is not possible for white blood cells to get out of the intravascular space into the tissue spaces where the inflammation is taking place. And then finally, we are saying that all these plasma mediators ensure a constant supply of what is required in order to maintain the inflammatory process until a time when the offending organism is totally resolved. 6 beneficial effects of inflammation, as we have seen. So now let us look at some of the harmful effects of inflammation, the not so good effects. Number 1 is the mechanical effects due to the swelling, and I think we mentioned this a little bit earlier when we talked about the presence of exudation. Depending on how fast and how much is forming, it will cause swelling, and this swelling or edema may cause obstruction or pressure on the surrounding tissues as well as the surrounding blood vessels. If the effect is on the blood vessels, then the area that is supposed to be supplied by that particular blood vessel will suffer ischemia, and that will even make the inflammatory reaction worse. Okay, and then we also have the mechanical swelling also, which may actually obstruct vital spaces, for example the upper airway, especially in young children whose necks are usually short, but even in adults. When the larynx is edematous because of inflammation, then that can easily interfere with ventilation, and the patient may suffer respiratory embarrassment. The second harmful effect is impaired function, which can be direct or indirectly. It is considered to be direct when it interferes with blood flow, leading to ischemic injury, and this can be so and very much manifest in a patient who is suffering from meningitis. If meningitis causes brain edema or cerebral edema, and that comes with obstruction of the blood vessel in supplying the brain, then you end up with mechanical brain damage because of necrosis following ischemia. Third harmful effect is sometimes acute inflammation may actually occur inappropriately. And a very good example of inappropriate inflammation is when in cases of hypersensitivity reactions. This is where a patient mounts an inflammatory reaction following invasion of otherwise harmless materials. So we shall look at hypersensitivity reactions much later when we shall be discussing the immune response. Having looked at the good and the not so good effects of inflammation, let us now take some time and look at the outcomes or sequelae of acute inflammation. There are mainly 4 possible outcomes of acute inflammation. Number 1, there could be total resolution. Secondly, there could be abscess formation. Thirdly, there could be healing by fibrosis and scar formation. Last but not least, the inflammation can become chronic. So we begin by resolution. When we say resolution, we mean complete restoration of the function and structure of the tissue that was inflamed. This complete resolution will usually occur when the inflammation is short-lived. That means it did not last a long time. So the shorter the inflammatory response or reaction, the better and the higher the chances of resolution. Also, when during inflammation, whether by its cause or by its effects, there isn't much tissue damage, again, then the chances of complete resolution are very high, as opposed to when the cause of injury is severe and also tissue damage is severe. The more severe it is, the cause and effect, the less likely that complete resolution is likely to take place. Now, during the inflammatory process or reaction, the offending cause can be removed or neutralized or killed by the inflammatory response. And that is the reason then the tissue structure and function can be restored back to normal. So that means complete resolution also does not just depend on the duration of the inflammation, does not just depend on the severity of the cause of inflammation, neither does it not only depend on the extent of damage, but also the success of the inflammatory response or reaction in reversing the process or the cause. If it is bacteria, it is removed, it is killed. If there are toxins, they are neutralized and cleared. That also contributes greatly to the success and presence of complete resolution. By and large, we are saying that resolution is the best and ideal outcome of inflammation. The second outcome is abscess formation. Abscess, we have already looked at what is an abscess. An abscess is just an accumulation of pus in an area of inflammation. And we have already also seen what is pus. Now, sometimes when this pus is accumulated, it will be surrounded by granulation tissue, and we shall look at the details of granulation tissue, what it contains when we talk about wound healing. All right. So there will be granulation tissue, and this can harden when the pus is not drained in time or it is not drained adequately. Pus formation is commonly associated with pyogenic organisms. That means organisms which predominantly, or bacteria, which predominantly attract neutrophils. Those organisms include the staphylococci. So we are saying staphylococci is the commonest. It is not the only one. The point is, anytime there is pus formation, as a clinician, you need to be thinking of bacterial infection, particularly the pyogenic organisms. Never forget that certain bacteria will predominantly, and most of the time predominantly, attract neutrophils, which are the chief pus cells. Now, sometimes an abscess may discharge spontaneously, but most of the times, again, it requires to be drained. Whether or not it drains spontaneously, it is good practice to make sure that you drain the pus completely and break all the canaliculi around the wound area so that there are no debris. Because if some of these are left, they may still contain some bacteria, and those bacteria may start regrowing or reproducing new toxins, and the inflammatory process begins again. Or if it's an infection, then it sets in motion again or even becomes worse. So it is very important that any patient who comes with an abscess, whether it's self-drained or not, then it is very important that it is surgically drained. That's a minor procedure depending, or major procedure depending on where the abscess is. The next outcome is healing by fibrosis or fibrous tissue formation and scarring or scar formation. So when you look at your skin, especially the young men or even the ladies, when you were a young child, you kept on falling, maybe engaging in dangerous games and then getting cut by the barbed wire and so on and so forth. And you healed and you had a scar. You still have a scar. The reason you have a scar is because you healed by fibrous tissue formation or fibrosis. And that is the reason the scar formed. So healing by fibrosis or scar formation occurs when there has been substantial destruction of tissue, and the tissue that has been lost cannot be replaced by tissue that is similar to it. We shall look at these details when we are talking about wound healing. Different organs, different tissues have different types of cells. There are certain cells that undergo regular turnover. We call them labile cells. Then there are certain cells that can never be regenerated when they are injured. Once they are destroyed, they are gone and gone. They will never come back. They are gone. Those ones must be replaced by an alternative means, and that alternative means is usually by fibrous tissue formation. Examples are like the cells of the nervous system. Examples of the labile cells which undergo regular turnover are the cells of the skin. That means, that is why sometimes you can have a scar on your skin, but after some time you discover the scar has disappeared. The reason is the skin cells are able to replace themselves every so often. And so even when there is injury to the skin, it is very easy for that tissue to be replaced by tissue similar to itself. In that case, there is no fibrous tissue formation and therefore no scarring. But where the tissue loss is much, even if it is a cell that is highly labile and can replace itself easily, but the tissue loss is too much for the existing cells to be able to fill or replace the distracted tissues or the destroyed tissues. In these cases, again, healing occurs by fibrous tissue formation or fibrosis. Okay? Chronic inflammation. So acute inflammation can progress to chronicity, and we consider that to happen when it has exceeded 2 weeks. So when a patient has presented with an acute inflammatory reaction or response and it is progressing into the 3rd week, then we say that it has progressed to chronic inflammation. It has progressed to chronicity. And this can go on even for many months, even years, depending. So what are some of the differences between acute, what are some of the differentiating factors between acute and chronic inflammation? So here we are referring to the chronicity of inflammation. So in chronic inflammation, there is greater tissue destruction as compared to acute inflammation. And the inflammatory infiltrate is a mixture of macrophages, lymphocytes, and plasma cells. Whereas in acute inflammation, the cells are predominantly neutrophils. Okay? And again, in acute inflammation, the tissue destruction is not as much as what we see in chronic inflammation. But we are saying that even when the tissue destruction is much, it will still start off as acute inflammation, only that it will not resolve within 2 weeks because of the degree of destruction, and so it will progress to chronicity. Second difference is that chronic inflammation is more productive than it is exudative. That means there is more tissue production. In this case, granulation tissue is more than inflammatory exudate formation. Okay? So there's more tissue formation, granulation tissue, more than the exudate formation. So you're not likely to get a lot of exudate forming there. What are some of the reasons or factors that contribute to occurrence of chronic inflammation? Number 1 is progression from acute inflammation. That means chronic inflammation can just occur as a progression from acute inflammation. Secondly, chronic inflammation can follow recurrent injury to a site which is already inflamed. That means that if a site is inflamed and it continuously, it is just disturbed, every time there is another injury on top of it, or there is a tissue that is preventing the acute inflammation from resolving, that can lead to chronicity. And then there are certain microorganisms which cause chronicity right from the beginning. So we are saying chronic inflammation can just be, inflammation can just be chronic ab initio, which means it can just be chronic from the beginning. And we shall see in which cases does that occur. So, progression from acute inflammation, let's look at PAS. The presence of pus is a leading cause or an important cause of chronicity. That is, when a patient presents with a simple acute inflammatory reaction or response, and then there is pus formation because of the nature of the inflammation at that site. Maybe the cause of inflammation is bacterial in nature, and then the pus persists for long. That persistence of pus will usually predispose to progression to chronic inflammation. And that is very important for you to remember. That means that any patient who presents with an abscess, he or she must have that abscess drained. Because if it is not drained or it is drained inadequately, then, like I said, the remaining particles may actually contain bacteria, and these bacteria may begin to regrow. They may begin to proliferate further. And when that happens, they cause more repeated inflammation and more pus formation. And so the inflammation becomes chronic. So like I said, if the drainage is not complete, then that can be a source of reinfection and reintroduction of persistent inflammation. Now, sometimes when this happens, the site of abscess or the abscess will usually try to drain it through the skin. When an abscess under, maybe it's in the muscle or it's infection of the bone, okay, and then it is bacterial in nature, and then this abscess is not drained, this abscess may actually form a sinus tract and discharge on the skin. So this drainage onto the skin is because of the formation of the sinus tract. All right, this. And so it just keeps draining and draining. And once it's become chronic, it becomes really, really hard to manage and control. Another reason besides pus that a patient may have progression from acute to chronic inflammation is the presence of foreign material. Anything that is foreign, whether it could be a piece of stone, it could be a piece of glass, it could be dirt, it could be a piece of cloth that may persist at the site of injury, will be a cause for chronic inflammation because there will be persistent suppuration. That means if a patient comes in and they have a traumatic injury with wound formation, then as a good clinician, you must clean that site of injury very well and make sure no particle is left. See, if a patient is involved in an accident or they fall down and the place is sandy or something like that, when they come to hospital, you must, what you call surgical toilet and drainage, you must clean that area very thoroughly, making sure there is no foreign material left. Otherwise, if that happens, then that is a stage for chronicity of inflammation, because these tissues cannot be digested. They remain there. They cannot be phagocytosed. They cannot be removed by the body mechanisms. And so they will constantly trigger an inflammatory reaction and the patient will never get well. Okay? Now, some of the reasons why, again, a patient may have chronic inflammation is because of recurrence of episodes of acute inflammation. By that, we mean that every so often, the inflammation is recurring. For example, if a patient has an injury on the somewhere, or just even on the skin, and when the scab forms, that hard crusty thing that forms on top of a site of wound when it is in the process of healing. When that forms, and maybe a patient likes scratching on it because sometimes it can feel scratchy. When the fibroblasts are depositing, it can feel scratchy. And a patient keeps scratching and breaking that black crust. What that happens is that it exposes the wound and makes it fresh again, and the inflammation begins all over again. So repeated bouts of inflammation. It could be because of trauma, it could be because of repeated infections or anything. So long as the episodes of acute inflammation are recurrent, that will predispose to a chronic inflammation. So what happens during recurrence is that inflammation sets in. Some healing is taking place. Then another injury is superimposed. Then it begins again. So the wound is usually at many stages of healing. So in between there are healings, and then there are new attacks which lead to inflammation. And so histologically, there will be features of both, acute and chronic inflammation. So sometimes the word continuing inflammation can be used to describe this situation that we have talked about. Then we talked about chronic inflammation ab initio. So this is when injury produces a chronic inflammation reaction from the beginning. I already said that. And so some of the reasons why inflammation may be chronic from the beginning depends on the cause. Heavy metal poisoning, that will predispose to chronicity from the beginning, because these materials will never be biodegraded by the body. Another reason is certain microorganisms, especially the obligate intracellular microorganisms like viruses. Viruses cannot cause infection unless they enter a cell. When they're outside a cell, they cannot cause disease. They have to enter a cell in order to cause disease. And then we have other bacteria. With bacteria, we have invasive, non-invasive, and then we have this one. So bacteria like leprosy, tuberculosis, these ones cause chronicity from the beginning. And of course, fungal infection. So depending on the cause of infection, inflammation, when we are referring to microorganisms, we are referring to viruses, fungus, and certain bacteria like leprosy and tuberculosis. And you shall learn more of these microorganisms as you continue in your study of clinical medicine. And sometimes chronicity of inflammation may just, the cause may not be known. However, some postulation may exist. So an example for this is rheumatoid arthritis. But rheumatoid arthritis causes chronic inflammation of the joints, and sometimes the cause is not found. However, it has been linked to immune reasons, which we shall see again when we discuss the immune response and diseases of the immune system. So when there is a chronic inflammation or inflammatory process, what do we expect? How does the tissue look like? What are the macroscopic features? This will usually vary, but by and large and commonly, there will be a chronic abscess. There may be a persistent sinus, like what we said when there's a sinus tract, so it will persist. There could be a chronic ulcer. There could be a thickening of the wall of a viscous organ. For example, if it is inflammation of the bile ducts, there could be thickening of the wall and eventual obstruction. There could be stricture formation, the smooth muscles or the muscles of the visceral tubules. They may not heal by primary intention. That means they may not heal by replacing with similar tissue. And when that happens, like I said, anytime healing cannot be done or effected by cells that are similar to what has been lost, they will be replaced by an alternative tissue, and that tissue is usually granulation tissue. Granulation tissue is just fibrous in nature, and so there could be stricture formation. It's very common when there is chronic urethritis or improperly treated urethritis, say in men, and they may develop with urethral stricture and therefore present with urinary obstruction. And there could be fistula, like in patients who suffer vesicovaginal fistulas. That's just because of chronicity of the inflammation, or there could be a chronic granuloma formation. All these are features, possible features of macroscopic features of chronic inflammation. Having said that, let's quickly look at the types of cells that you expect to see at a site of chronic inflammation. All these, the macrophages, lymphocytes, plasma cells, neutrophils never go anywhere. They'll still be there, and then eosinophil, polymorphs, and fibroblasts. And with that, we have come to the end of our third lesson for today. I want to thank you for your attention and for stopping by. These are our main reference materials. Like always, I encourage you to go and read further and make your own notes accordingly. Goodbye and God bless you.